yesterday. So in terms of retrospective on day 2, we had a bunch of material that we addressed yesterday. I believe we began the day with some additional work related to putting in place some reporting for that weight and diabetes case that we had in place. We put in place some mechanisms to display pie charts and to display time plots associated with burden, and we supported them through the use of statistics. And the important point here is that there are a set of processes operating in models that go beyond the processes operating in the world. These models, they serve to capture the logical consequences of dynamic hypotheses concerning processes going on in the world. But in order to function and to provide us with the information that we need, often within the models, we have processes going on which not only mimic or emulate processes in the world, but also processes that report to us, that are what I call epiphenomenal. They don't change the course of the model evolution, rather they give us insights about what's going on in the model. And as time allows, today or tomorrow, more likely tomorrow, we might cover some additional types of output. How you can take model data from any logic while the model's running, and you can put it in a database, or you can put it in a spreadsheet, or you can put it out to a file that you could then use open in R or SAS or Stata or your favorite tool. So we'll see that often these epiphenomenal reporting processes are of significance both for the research and for insight, exploratory insight while the model's running. And we saw how we could put them into place with the model. However, much of the day yesterday was additionally spent on discrete event modeling. We introduced some of the building blocks of discrete event models. We noted that discrete event model captures, with a great economy of expression, captures the flow of entities in health, commonly people, through a set of resource-constrained workflows where the progress of that individual down that workflow is contingent upon the availability of resources. And although yesterday we didn't have a chance to explore it together, these models additionally can capture the spatial interactions of these individuals within a facility. So you can have, for example, movement of these entities and the resources to support them in the context of a clinic or the context of a hospital, context of an emergency department, in a way that that movement, the mobility patterns and the amount of time required for mobility is endogenized. It's generated by the model rather than being pre-specified. And what that means is that in intervention scenarios, we can ask questions not only about the outcomes if we change the level of resources available, but also the placement of those resources, where they are placed within the facility. And outcomes of common interest here would include health outcomes for sure, but also service delivery outcomes such as throughput, the number of people that you're able to get through your facility per, pick your time in a day, week, month, or what have you. Also something about the waiting times. I don't know in Canada, but I don't know in Australia, but in Canada, waiting times for certain types of elective surgeries, certain types of emergency appointments, or for emergency departments are of some concern and are commonly a political hot button. About why people wait for so long for a hip replacement surgery or knee replacement. So waiting times are another possible outcome. Another possible outcome would be latency, how long someone spends from one point in the whole process to the other. And yet another might be quality of service that's rendered. So we're all, and finally, resource utilization. What fraction of the time are the nurses simply themselves kept waiting? What fraction of time is our MRI machine really being used? If it's too high, people might think, or very, very high, people might think about bringing in a second machine. If it's very low, people might think, well, maybe we can do a better job getting people to this facility rather than facilities which are in very high demand. For all those tasks, discrete event modeling provides a very nice lens. We saw these primitives for discrete event modeling came in these little building blocks. We saw primitives like establishing a resource pool, seizing those resources, releasing those resources, representing sort of delays associated with procedures or workups or what have you. We saw that there were operators that could be used to branch. So you could have uncertainty about which direction you go in the process, or a branching that would depend on patient's characteristics, for example. Now, these processes, the way we featured them, it's been in the context of a very concrete service delivery, a clinic. But one has to remember that when it comes to characterizing workflows, there's a much broader set of workflows associated with health issues. Surely, primary care physician seeking and seeking for acute care support for elective surgeries, that has relevance. But there's also cases where individuals seek to enroll in a program. Perhaps it's a program associated with an intervention to build healthier communities. And you can represent the flow of people within that program, sort of their processing and the stages they go through in a way that might affect their behavior could be captured in a discrete event model. Or for other types of processes like contact tracing for infectious, for notifiable diseases, you could have the contact tracing process included in there. So it's not always a person goes to a facility and gets treated. Service delivery in its various forms can take place in the context of a wide variety of interventions, screening procedures, etc. One is at a certain stage of some administrative process, and that ends up affecting a person. Now, in the latter part of yesterday, we ended up exploring a hybrid model. And this hybrid model had a number of features that I'll emphasize, but one of its key sort of raison d'etre was to be able to join together, on the one hand, a representation of a person's health status, and on the other, a representation of a service process. So we had people who were undergoing health transitions, and they presented for care at a facility. And within that context, we had this person whose health evolution was ongoing here, with some sort of infection where there was little in the way of immunity, something like gonorrhea, where the outer membrane protein evolves over time. And then we had a caregiving sort of set of processes represented in the context of a person. And with a certain chance over time, someone who was ill could present for care at a process. So in the condition that someone were ill, were infective and symptomatic, with a certain chance per day or per month, they could go move to a clinic. And they found the nearest clinic to them, they moved to them, and then they enrolled in that clinic, and that was achieved via this. having enrolled in the clinic, they were then placed in the clinic workflow at this walk-in place. So to be clear here, we had this person coming in here, and they said to this walk-in position in this process, take me in here. And they then flowed through this process. So the population health here, the health of the population was driving people into service requests. And as they flowed through here, we had outcomes which were specified not only in terms of the number of individuals who are processed, but also outcomes that would affect the health of that individual. So particularly here, ladies and gentlemen, if they went out via this upper condition here, in other words, if they left here with a cure, they were actually sent a message, cured, and what that did is that brought them back into a susceptible state. It was like an antibiotic treatment that was successful, and they were brought back into a susceptible state. So in short, population health was driving service presentation, and the service delivery and the quality of care conferred was driving health changes, in this case health improvements, lowering of the burden of illness associated with that particular individual. Now, that's how sort of things were set up at a mechanical level, but there were a couple components of this that I'd like to emphasize. One thing is, we had this very significant factor that people could be cured from infection, which is notable here. This was a treatment-mediated recovery. Absent treatment, they could not actually make their way back to susceptible. And now, with a clinic in place, one or more clinics, we could have them treated. But we noted, and we'll probably come back to this issue because it's an issue of some note from a systems perspective, that if we were to go run this model and we were to watch as the model progressed, there's a very high burden of illness. And we'll come back and modify that later. We'll see how we can use branches and so on. And particular individuals, indeed, they develop this complaint. They get to this affective and symptomatic state, and periodically they present for care and are cured. But at a system level, so while at an individual level they're cured and provided great benefit in the short term, they are thrown back into a population which still exhibits very high rates of infection, very high prevalence rates of infective and symptomatic. And because, and this is very important, we are spreading this message over a network of people who are connected up, these individuals who recover, who are brought back, who recover from the infection, they're brought back to a susceptible state, they quickly become infected again. So we've put in place a mechanism which ostensibly, on the face of it, allows someone to recover. But from a systems perspective, we've done comparatively little for the health of the population. We throw them back into their networks, and they quickly become infected again. We've encountered what might be called policy resistance. We put in place an innovation that we think from a biomedical perspective could confer a great benefit, curing people 95% of the time. But we find from a systems perspective that that we're not actually gaining much by it at all, because we have people thrown back into their networks which have lots of other infected people, and they quickly become reinfected again. And we have some papers in the committee area which examine some effects like this in the context of what's called the arrested immunity hypothesis, advanced by Bob Brunham at the BC Center for Disease Control. But it's a notable sort of systems level phenomenon. You get a lot less benefit than you might think. And we saw with this sort of setup that we could add in here some additional clinics. And that might help some in lessening the burden of illness, but still there's a lot of people getting infected again. I'm actually running this with a smaller population here. No, it is the full population. Okay. In any case, we added clinics in, and now people spend a little bit more of their time recovered, but they still get reinfected easily. So we're going to come back to this example to examine some of the impacts of behavior change as time allows, capturing behavior change and capturing prevention efforts, both targeted and more general. But I wanted to draw out a couple more features of this. So a second feature that we talked about, that we introduced with this example, which is a multifaceted example, we examined the effects of having networks in place. And just to sort of make this very visible at the cost of a little bit of visual confusion, I'm going to go to person again, and I'm going to draw a line connecting people, and I'm going to run the model from the start and just use it to show the fact, to demonstrate the fact that we do have some network present. Oh, okay. Pardon me. Okay. Yes. Okay. Okay. So here we have a network. Okay. So my computer is exhibiting displeasure. Okay. There we go. So here we have people embedded in networks, and networks are well supported in any logic. We have a set of roughly 5 or 6 network types: distance-based, scale-free, small world, a what's called Poisson random network, also called a Bernoulli network, also called Ergos random network. We further have distance-based networks such as this, where any pair of people are connected if and only if they lie within a certain distance of each other. We used 75 yesterday, and we also have a more theoretic construct called the ring lattice network, which is similarly local, but it exhibits that locality in one dimension. So everyone is sort of arranged conceptually in a ring and are connected with neighbors to the left and right of them only. And these network structures have profound effects on the spread, can have profound effects on the spread of norms, attitudes, beliefs, and pathogens like here. They're often form a very important component of modeling. And when it comes to something like physical activity, it may be that there's a certain amount of imitative behavior that spreads via networks. Norms of weight and what constitutes a desirable or normal weight range is also spread through networks. And we can capture those sorts of effects fairly readily in the context of this. And some of the first examples we opened, there was one of them that I had you open on Tuesday morning as one of our introductory examples, where people's physical activity was influenced by those around them within their network. So networks were an important part that I wanted to weave in yesterday, and as time allows, we may explore them some more as well. We additionally, however, captured some components associated with mobility here. So we had individuals who would move to the clinic to get treated and back. Now, we didn't really take advantage of that here. We didn't really make use of the fact that they were moving to materially affect things, but there are times where we will wish to do so, that the time it takes to go from A to B could be quite central. I know one of the folks who was hoping to be here today, Masa from our MIT, she is a model where she's very interested in ambulance routing in the context of a stroke, where each minute makes a difference. And there, the mobility is not merely just sort of something to help show to stakeholders, just give them a sense of what's going on, but rather it's something which is quite central. And exactly how long it takes you to reach from that person's home where they suffered this TIA or stroke to a facility may make all the world of difference. And there are other cases where that mobility might bring somebody in contact with services or with resources that might be important. Think about a person who lives in one location, works in another location, takes a bus between them, and that bus provides access to fresh fruits and vegetable stores, or provides access to parks. That mobility and the exposures that they get on that mobility might influence their sense of the food environment, their sense of the built environment in terms of physical activity support in a way that would have material impact. And much of the work we do with our smart verb-based sensing, we're very interested in the exposome, the set of things to which we're exposed day in, day out as we circulate in activity spaces. And we can capture elements of that in our modeling by examining the trajectories people take. And indeed, today, in this very classroom, in coming hours, we will be exploring GIS-based models that do a similar thing and that route people on road networks. So this aspect of mobility we had here made clear sort of what was going on in terms of presentation to clinic. You could see as they're moving to clinic, red, come back green, for example, or in case of treatment failure, return red. A little bit of what was going on, but it was a little bit epiphenomenal here. It wasn't driving the dynamics of the model in a very material way. There are models where it does do so. We further saw that within this context, there are networks that might be formed based on an individual, and those networks actually might change when they present for care. They come into contact with others. So think about an intervention which focuses on, so in our, we're very privileged in our work to have partners in the form of a community-owned grocery store. This is actually a very notable intervention which has taken place in our community in a food desert, what was previously a food desert in a core area. And this grocery store is a very substantive store that offers fresh fruits and vegetables in an area where they were hard to come by previously of town, but it further offers cooking classes for people to learn to share cooking skills. It also offers the opportunity to get into networks of people who will go to fresh food markets, and also to enroll in programs for well baby programs to help in the earliest years of childhood. And I believe there's also a link with programs to have fresh fruits and vegetables delivered to your home. So there's kind of a nexus of services at this location that are co-located. And so someone going there might take advantage of some of these other services too. And that might think about cooking classes. That might help shape norms, attitudes, beliefs of concerning food consumption. More than that, it changes the social environment. Suddenly they're taking classes with other people who have an interest in healthy eating as well. And it links people up together in a way that may have, long after the class itself is over, may nudge that person's trajectory in terms of how they cook, who they spend time around, and their norms, attitudes, and beliefs with respect to food. So we can capture effects like that by having people's networks change by where they are in space. So for example, within the cooking class, it builds their networks. I mentioned earlier Winston Churchill's dictum. We build our buildings and then our buildings build us. He was talking about social housing in the UK. But the same thing is true with networks, right? You elect to go to a cooking class, and by so doing, you're surrounded by people with some similar aspirations, and then you are shaped by them in future years. So we can capture effects like that with these models, and I'd be happy to elaborate on that later, how that could be done. I'm hoping to come back to this model, ideally late this afternoon, maybe tomorrow to really look at interventions, behavior change, preventive measures, look at some of these system effects that we saw. Okay, but today we have a full day ahead of us also with GIS. So we have found that that requires some time to drive forward. We're going to build a rather articulated model that takes advantages of AnyLogic's GIS functionality. And it is to that prospect that we now turn. Okay? So any questions about what we saw yesterday before we go on to this new material for GIS? Prospect? Any discussions? No? Okay. So with your leave then, I will close this model and with our plan in place to return to it, we will go and start with a clean slate. And I'll